Hello everyone, it's Professor Leon. Today's topic that we will discuss is about elimination, and to be precise, we will go over incontinence and BPH. Be aware that this online presentation is for current students in the OA course and may not be shared without permission. So what do you think about Golden Years code? To be specific with your urinary system, as we step in to our golden years, our bladder may become less elastic as you age, of course, and that would result in the need to urinate more often. We will experience weakening of the bladder muscles and the pelvic floor muscles, which make it difficult for us to empty our bladder completely or can cause to lose bladder control. So when we lose bladder control, that's another term for urinary incontinence. In men, an enlarged or inflamed prostate also can cause difficult emptying the bladder and incontinence. Other factors that could contribute to incontinence include being overweight, any nerve damage from diabetes, certain medications, and caffeine or alcohol consumption. All right, so for this slide, basically it tells you the basic care and comfort for elimination. So first, we're going to be able to assess and manage client with alteration in elimination. We're going to be performing irrigations. It is also expected that we provide skincare to clients who are incontinent. So by making sure that we wash them frequently and use barrier ointments or creams. Another thing is to be able to use alternative methods to promote voiding. And of course, we need to evaluate whether the client's ability to eliminate is restored or maintained. As I've said before, our body was designed to be in balance or in the middle. So same thing with the urinary system, continence. So in order for continence to occur and maintained, certain needs must be met. First, we need effective functioning of your bladder sphincter mechanism and the pelvic floor muscles. Also, we need to have an effective functioning of the autonomic nervous system, micturition centers in the brain, and locomotor skills. Although there are normal changes in the genitourinary system that make older adults more susceptible, such as decreased bladder capacity, delay in sensory signaling bladder fullness, incontinence is not a normal part of aging. Incontinence occurs when pressure in the bladder exceeds the urethral resistance. So the difference between retention and incontinence is basically both of them are issues in your urinary system, but they are completely opposite problems. So remember, incontinence makes it hard to hold urine, while retention makes it hard to expel urine. So for this table, you could refer to table 5-6, which is found on your textbook, page 294. And we're going to actually go over 3 common types of incontinence. So the first one is stress incontinence. What it means is loss of urine related to increased intra-abdominal pressure. Urine loss basically occurs when you're sneezing, coughing, lifting heavy items, and is usually a small quantity. Contributing factors could be decrease in estrogen levels, multiple pregnancies, prostate surgeries, abdominal wall weakness, ascites, obesity, tumors, all causing increased intra-abdominal pressure. Another common type of incontinence is urge. So with this one, there's a loss of urine that is associated with a strong urge to void. Contributing factors may be neurological disorders, overactive detrusor muscle. So remember in your A&P, your detrusor muscle is a smooth muscle which is found on the wall of your bladder. It remains relaxed to allow the bladder to store urine and contracts during urination to release urine. With urge incontinence, the ability to inhibit voiding is impaired. Overactivity can be associated with bladder outlet obstruction, aging, or diabetes. Now, the third common type of urinary incontinence is functional. This one, basically, there is a loss of urine related to physical, environmental, or psychosocial causes. The ability to respond to the need to void is impaired. What are the contributing factors? It could be because of physical disability, confusion, dementia, sedation, or depression. Patients can develop more than one type of incontinence. Having mixed urinary incontinence, usually stress and urge. So on our module, I have uploaded articles and few other information that may be helpful for you to go over this homework. And that homework basically are the 3 case studies presented in this slide. It is required that you complete this homework prior to coming into our in-person activity. Now, whether you do it individually or you want to have 2 or 3 more people join and go over the questions with you, that is all your option. For our class to be more meaningful, it is important that we learn the material before coming and you are all prepared for discussion. Benign prostatic hyperplasia or BPH. So what is it? Non-malignant enlargement of the prostate gland commonly seen in aging males. So pathophysiology of BPH, basically there's a narrowing of the urethra due to increase in number of cells in prostate, resulting in partial or complete obstruction. Basically, it blocks the flow of urine due to the narrowing of your urethra. As the prostate gets larger, it starts to pinch the urethra. This causes symptoms that affect the flow of the urine. When the urethra is squeezed, it also means your bladder has to work harder to push urine out. And then over the time, the bladder muscles get weak, which makes it harder for it to empty. So basically, there are 2 categories or types of symptoms. So in regards to voiding, probably there's going to be a weak stream, increased time to void, maybe hesitancy, incomplete voiding, or there's this thing called post-void dribbling. Storage-wise, as I said, there's that frequency, urgency, incontinence, nocturia or using the bathroom a lot during the night, dysuria, D-Y-S-U-R-I-A, basically it's the feeling of discomfort when voiding, and probably bladder pain. Some of the risk factors, again, includes age and, of course, presence of testes. It's only in males. Most common benign neoplasm in men, it begins roughly around 40 years of age. Um, More than 50% of men in their 60s have symptoms. 90% of men in 70s and 80s have symptoms also. Unknown cause could be because it could contribute to diet high in red meat or fats. And for some reason, it's more prevalent in our African or Hispanic versus a white male. The development of BPH is not clearly understood. However, we do know that a change in DHT, delta, Harry, theta, if I'm saying it correctly. So basically DHT, or the long name of dihydrotestosterone hormone, occurs with aging. Testosterone is changed to DHT, then binds to prostate. DHT and prostate are needed for development of healthy prostate. DHT can be detrimental in the adult prostate in that is causing pathologic prostate growth. At puberty, the prostate doubles in size and then starts to grow again at around 25 years of age. For some males, it continues to grow for the rest of their life. For some men, this will lead to BPH, while others will not. The size of the prostate does not necessarily relate to the severity of the symptoms. Again, it's different for each person. Some men with very large prostates have few, if any, issues. In regards to nursing problem or diagnosis, you could almost always use impaired urinary elimination. Another option could be urinary retention, can lead to overflow incontinence. All right, so the slide here, there's a question. Before surgery, patients with BPH are at risk for experiencing which type of elimination problem? Is it A, stress incontinence, B, urinary retention, C, functional incontinence? So I'm going to give you guys 5 seconds to maybe think about it. All right, so from the choices we have, it would be before surgery, the problem probably will be urinary retention or overflow incontinence. What happened is the involuntary release of urine from an overfull bladder, often in the absence of any urge to urinate. Now, following surgery, the same patient with BPH are at risk for experiencing stress incontinence. So, what are we assessing in regards to BPH? So, system assessment, again, inability to empty the bladder. You could also find over distension and frequent loss of small amounts of urine. Complications could include diverticula of the bladder or an outpouching. Infection, again, related to retained urine over time. You could also have hydroureter, which means dilation of your ureter. You could also have hydronephrosis, meaning there could be a dilatation or distension of your renal pelvis, and eventually it could lead to kidney damage and failure. BPH does not lead to prostate cancer, but risk factors could be the same. Now, you want to always assess medication use because 10% of lower tract symptoms in men is related to medication use. Specifically, the over-the-counter cough or cold medications, your antihistamines, decongestants, and anticholinergics. These medications basically cause urinary retention by affecting those nerve signals. What are the tests for BPH? There is this thing called PSA or prostate specific antigen, and the doctor could also do a digital rectal exam, which we call DRE. The exam is done yearly for men over the age of 50. And of course, symptom assessment, they would also do urinalysis. They're gonna probably do post-void residual and medication assessment. Just be aware that PSA or prostate specific antigen is not diagnostic. Um, the levels of 4 nanogram per ml or higher basically um, would be referred for a biopsy. Sometimes PSA test alone is not accurate, so they would look into the presence of UTI or infection can increase those PSA levels. Medications normally to treat BPH will lower PSA level, such as your finasteride or dutasteride. So how do we manage BPH? Evidence say, I am referring you to the article that's found on your Canvas, done by Pearson and Williams, who needs to be treated. So men with mild symptoms, non-bothersome to moderate symptoms, may not require treatment only because they are not likely to experience further symptoms. Now, bothersome moderate to severe symptoms require treatment with lifestyle modifications, medications, and surgery. The American Urological Association Symptom Index is basically adopted worldwide, and it is a self-administered symptom questionnaire. And whatever the after the patient and the doctor do the survey questionnaire, that would classify them whether this man is on non-bothersome versus severe symptoms. What are the first line medications? The first line medications are your alpha blockers. So what are the drug of choice for treating BPH? First, as I said earlier, the first line is your alpha blockers. And what it does, it improves the symptoms and increase the flow of the urine by relaxing the prostate, neck, and bladder. And it goes through that sympathetic activity blockade. Now, another drug of choice is the 5-alpha reductase inhibitors, and it works by inhibiting basically the conversion of testosterone to DHT, which causes shrinkage of the prostate. So on this slide are the meds typically used for patients with BPH. A 2-med combo is usually most effective for long-term management. 5-alpha reductase inhibitors again work by inhibiting conversion of your testosterone to DHT, which results in shrinkage of your prostate. Dutasteride and finasteride, the side effect could be sexual dysfunction, decreased libido, decreased ejaculation volume. You want to caution anyone, any pregnant women, they should really not handle this medication because the adverse effects to a male fetus is ambiguous genitalia. Another thing that the FDA now requires on this medication is to include a warning that they may also be linked to an increased chance of high grade or aggressive prostate cancer. As I said earlier, the first line treatment for bothersome moderate to severe BPH is your alpha adrenergic blockers, and they work by blocking excessive bladder smooth muscle contractions. Your doxazosine and prazosin, their side effects include orthostatic hypotension, headache, and dizziness. So there is also this thing called first dose phenomenon for your alpha blockers, and what it means is a severe hypotension and syncope, and also tachycardia within 90 minutes of the dose. Mostly it's noticed when your patient goes from lying to standing position, which we all know is called orthostatic hypotension. Maybe taking this at bedtime would limit the effects. And then your last two, tamsulosin and terazosin, avoid tamsulosin in patients with planned cataract surgery because it could increase the risk of intraoperative floppy iris syndrome. Now your anticholinergic, which is tolterodine, what it does, it results in decreased bladder contractions. It can also be used, but includes the risk of urinary retention. It's not for use of post-void residual greater than 250 ml. It is basically used for urgency and frequency symptoms. The problem with this one is that it dries everything up. You can't see, you can't spit, you can't pee, you can't poo, because anticholinergic basically dries you up. So what are the collaborative nursing interventions for patients with BPH? Absorbent pads if needed, catheterization for retention if needed. A Coude tipped catheter is basically passed more easily in the older man with an enlarged prostate. It requires a doctor's order. There's no evidence to prove that dietary supplements are effective once BPH has developed. In regards to patient teaching, you want to educate them to avoid decongestants and antihistamines. Again, the side effect is the retention. It interferes with nerve signals. Non-pharmacological therapy, you could look into page 307. And then in regards to lifestyle modification, there see article page 771. Again, it's important because often use watchful waiting with mild, bothersome BPH symptoms. Urinating at the first urge. You want to avoid alcohol and caffeine and highly seasoned foods. Only drink small amounts of fluids spread throughout the day. You want to tell them to avoid drinking fluids within 2 hours of bedtime. Avoid those over-the-counter cold and sinus medications that basically contains decongestants or antihistamines. You want to encourage them to exercise regularly, including Kegel exercises. Of course, stress reduction, and if they're obese, to lose weight. Another management for BPH is surgery. And the surgery that they use is called transurethral resection of the prostate, or TURP. Again, this is only for severe or bothersome symptoms. Remember that TURP is considered the gold standard procedure for BPH. What happens is the scope is used with an electrical loop that cuts tissue and seals blood vessels. Fluid is flushed into the bladder during surgery and then drained. The goal is to limit surgical time. In this picture, you can see the prostate being scraped away and cauterized during a transurethral resection of the prostate or TURP. During surgery, the pieces of the prostate are flushed into the bladder and then drained out at the end. The prostate is vascular and there is a high risk for hemorrhage. Risks include, again, hemorrhage, clot retention, inability to void, incontinence, UTI, impotence, retrograde ejaculation, and TURP syndrome. Now, TURP syndrome is rare but a life-threatening complication that occurs as a result of absorbing bladder irrigation fluids into the prostatic venous sinuses. Large volumes of irrigate means fluid volume overload. It can occur within 15 to 24 hours post-op. And what are the signs and symptoms of TURP syndrome? Basically, restlessness, headache, tachypnea, or burning sensation in face and hands. That burning sensation in face and hands is actually the early sign of TURP syndrome. So after surgery, a three-way irrigation catheter is placed. The three-way catheter has three ports, one to blow up the balloon, one to flush or irrigate fluid into the bladder, and one to drain the fluid and urine out into the catheter bag. The catheter is larger, 18 to 22 French, and the balloon is bigger. It could hold about 30 to 45 mLs in the balloon. After the catheter is inserted, it is pulled down into the prostatic fossa. This holds pressure on the surgical site. The catheter is then taped to the leg to apply traction. Nobody should be manipulating or changing the position of the catheter. If it becomes dislodged, the on-call doctor needs to be called. So in the picture, you can see two large 2 to 3 liter fluid bags hanging. Those bags usually contain normal saline. And normal saline is isotonic, meaning fluid should not be absorbed into the intravascular space. The irrigation must always be maintained. The nurse always needs to be prepared with extra fluid bags. The purpose of the irrigation is to continuously flush blood clots or blood out of the urethra and bladder in order to keep the urethra patent. Basically, think of a straw that needs to stay open. The patient will have a much larger drainage bag. The drainage bag collects both urine and irrigation fluid. Okay, so continuing on post-op TURP care, patient will have a three-way irrigation catheter with continuous bladder irrigation, also known as CBI. Nursing care, maintain traction. Urine should be light pink, scant, or rose-colored, progressing to a lighter color over time. Assess for clots or frank blood. Traction basically decreases the risk of hemorrhage. This situation can create sensation of needing to void, so you want to discourage the patient to strain, around the catheter. Also, if there's a blocked catheter, it could again cause a sensation of needing to void, so you want to assess patency. So report bladder spasms. Again, it could be because of blocked catheter or hemorrhage. So what are the signs of hemorrhage? Frank blood could be a sign. Hypotension with tachycardia, again, could also sign hemorrhage. Now, for dehydration or blocked catheter, you could have, again, decreased urinary output. Also, leaking around the catheter could mean a blocked catheter. So what are you going to do for, let's say, frank blood? Report immediately. to the doctor. You're going to increase fluid rate. Again, watch for the signs of hemorrhage. No output or bladder spasm, leaking around the catheter. Again, what you would do is to check for patency. You may need to manually flush it and increase the rate. Now be careful when you're increasing the rate, especially if catheter is blocked. It could cause some discomfort. Bladder spasms could be treated with ditropan or belladonna and opium suppositories. Again, it's a narcotic and antispasmodic. Again, it prevents spasm. Irrigation is always maintained, so make sure you have backup bags. Nurses usually are specially trained to do this care. There is no particular rate. Flow of fluid is to flush out the clots and to make sure that we keep the urine in a pink rose-colored output. You hang 2 to 3 liter bags at the same time, and ideally fluid at room temperature. Can be saline or special mixture. Again, something isotonic so fluid is not absorbed or pulled out. TURP, it is removed by the doctor after 24 to 48 hours, so you want to ensure you have an accurate or equal isonos. You'll probably have more output, again, due to the urine output. Remind patient to avoid straining when voiding, and having a bowel movement may stimulate bladder spasms and pain. And again, there's also the likelihood of increased risk of bleeding. You want to monitor for that TURP syndrome that we talked on the previous slide. Again, as nurses, we need to maintain that traction and irrigation at all times. And then for the INO, what goes in must come out. So irrigation solution goes in, irrigation solution and urine come out. So if 100 ml per hour is infused, a minimum of 130 ml of fluid needs to be drained. So you're probably going to say, why? Well, the 30 ml is the minimum amount of urine an adult patient voids or produces per hour. Just want to go back to that TURP syndrome. Again, it's a rare complication characterized by fluid volume excess. The risk is increased if the patient has a prolonged surgery. During the surgery, the irrigation solution being used can be absorbed into the intravascular space, and that could lead to fluid overload. So what are the symptoms? May include low sodium level, increased blood pressure, low heart rate, and also confusion. Continuing post-TURP care. Nurses who care for the post-TURP patients are specifically trained in monitoring these systems. The nurse needs to balance the irrigation rate in order to produce an output that appears pink or blood tinged. If too little fluid is irrigated in, it can allow the blood to clot in the urethra or bladder. We do not want the bladder to become occluded with blood. The goal is to see urine become progressively clearer, meaning diminished amount of blood. The drainage is often described as rose-colored or blood-tinged. The catheter, again, as I said earlier, is removed by the physician after 24 to 48 hours. If the nurse notes frank blood, this means bright red blood. The rate should be increased and the physician immediately notified. Bright red blood indicates active bleeding, possibility of hemorrhage. So, urgent intervention is needed. If the patient complains of bladder spasms, you want to assess patency, meaning that the fluid is draining. If if patient has an order for a PRN med for an anticholinergic or antispasmodic medication like the belladonna, which is suppository and opium, or oxybutynin, give it. If there is no output, you want to attempt to increase irrigation to flush the clot out. If the output does not resume, you want to call the doctor immediately. Again, urgent intervention is needed. Reports of discomfort or leaking around the catheter. Again, assess for patency of the catheter. Assess the color of urine being drained, and follow the steps above. All right, so this slide basically is kind of like an INO type of calculation. I need you guys to look into this, do the calculations, and then when we meet in person, we're gonna go over the calculations, making sure we get the same number. And then the most important thing here is, do we call the doctor after getting the urine output? Of course, finally, we have to make sure that when the patient is ready to go home, we do teaching. So teaching should include reminding them again to avoid decongestants or any antihistamines. The side effects are retention because it interferes with nerve signals. I need you guys to look at non-pharmacological treatment that is on page 307. In terms of lifestyle modification, there are common questions about BPH article on page 771. Another thing is losing weight. You want to remind them to decrease evening fluid intake and avoid excessive alcohol, caffeine, or highly seasoned foods. Limit meds known to cause lower tract symptoms. Again, it's important because we often use watchful waiting with mild, bothersome BPH symptoms. Another thing you could use is to review patient teaching, which you could look into your book, page 316, and box 5-2 on page 317. After the removal of the catheter from TURP, you want to encourage Kegel exercises and do a start-stop stream while voiding several times during the day. Again, remind them that it may take up to 1 year to regain total control. You want to also encourage them to increase fluid intake 2 to 3 liters a day. Remember, discharge instructions are very important due to the length of time it takes to recover from this surgery. You want to review the areas specific to activity, bleeding, bowel movements, diet, urination, work, and also when to call immediately. Review patient teaching on page 310 and discharge instructions after prostate surgery on box 5-1. In terms of evaluation, basically you're gonna want to evaluate, is patient continent, is there reduction in symptoms or no more symptoms. Again, if you have any questions, please feel free to email me, or you could also post your questions on the discussion board titled BPH/elimination. Thank you.